Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany, and I would like to report 5 exciting studies from March 2022. I would like to start with a landmark paper in Lancet about the future therapy of Duchenne's muscle dystrophy. You all know this disease, which is a progressive atrophy and paresis of muscles, first in the lower and then in the upper extremities, and also with a cardiomyopathy. The life expectancy today is about 20 to 40 years. There is now a new gene therapy, but we definitely need also alternative therapies. And this paper published in Lancet describes the use of stem cells. And these were, in this case, cardiosphere-derived stem cells. And these were already used in the past for the treatment of cardiac failure. These cells obviously have immune modulatory effects, antifibrotic effects, and regenerative effects. And the mode of action most probably is via exosomes. In this placebo-controlled trial, patients with Duchenne muscular atrophy and upper extremity motor function limitations received either cell therapy or placebo every 3 months for 1 year. 8 patients received stem cells and 12 patients placebo. And the patients who received the real treatment showed an improvement of upper limb muscular function, and the ones who were treated with placebo showed a deterioration. Now, this treatment was relatively well tolerated. 3 patients had hypersensitivity reactions. Now, if this turns out in a larger and longer trial to be an effective therapy, this would really be a breakthrough for the treatment of muscular dystrophy. The second paper, also published in Lancet, deals with prion diseases, Jakob-Creutzfeldt disease. You all know this disease. Prions are misfolded proteins, and they act like an infectious agent and distribute throughout the brain. A research group in the United Kingdom now developed human monoclonal antibodies against the prion protein. And they treated 6 patients with Jakob-Creutzfeldt disease, and they have indication that these treatments could work. Well, at the end of the day, all of these patients died. But in 2 patients where neuropathological examinations were possible, they could show that the antibody is present in the brain at areas where you expect it to be. Now, what is the future potential of this treatment? I think the most important would be in the hereditary prion diseases, to see whether you treat patients who start to show symptoms with these monoclonal antibodies, whether you can slow the disease. The third paper, published in the Journal of Prevention of Alzheimer's Disease, deals with a very controversial issue, and this is the use of aducanumab in early Alzheimer's disease. This is a drug that is a monoclonal antibody against amyloid beta. And now finally, the 2 phase 3 studies were published. These were trials in patients with early Alzheimer's disease, proven by amyloid PET criteria. And each of these studies had 1,600 patients. Now, these studies were terminated prematurely due to futility when 50% of the patients were recruited. The company then performed a post hoc analysis and found a positive result in one of the studies and a neutral result in the other one. And this led the FDA to approve this treatment. EMA has rejected the approval of this drug. Now, what is the problem? The problem is that the benefit, if there is any, is small. And 30% of patients develop brain edema, which can be shown on MRI, and this means beyond the high cost of the treatment, these patients have to undergo MRI on a regular basis. Whether these high costs are really justified compared to the small benefits that it's in is really questionable, I think. Now, the next study, published in Neurology, deals with long-term ECG monitoring after stroke or TIA to identify silent paroxysmal atrial fibrillation. And the group of authors did a meta-analysis of altogether 8 trials, 5 randomized trials and 3 observational studies with 3,000 patients, where long-term ECG monitoring, usually with implantable devices, was compared to standard of care, which is intermittent ECG recordings. And they observed, which is not a surprise, a 2 to 4 times higher probability to detect atrial fibrillation with implantable loop recorders. But unfortunately, this did not result in a reduction in the risk of stroke. Well, this could be a question of statistical power, but the consequence in some European countries, unfortunately, is that the healthcare providers in some countries now refuse to pay for implantable loop recorders. And the last study published in Stroke deals with cerebral sinus venous thrombosis. You all know that in the acute phase of this disease, patients are treated with heparin or low molecular weight heparin. And long-term treatment until now was warfarin to prevent recurrent thrombosis and to promote recanalization. And the authors did an observational study, and they looked at altogether more than 800 patients with cerebral sinus venous thrombosis. Now, 33% of these patients received a direct antagonist, for example, the bigetran or rivaroxaban or apixaban, and 52% received warfarin, and the remaining patients both. Now, they observed a rate of recurrent venous thrombosis of 5.7% per year, 4% major bleeding complications, and 1.8% mortality. In terms of recurrent thrombosis, recanalization, and death, there was no difference between DOACs and warfarin. But in terms of major bleeding, the risk of major bleeding was reduced by 65% for DOACs over warfarin. And this would be a very strong argument to use DOACs in patients with cerebral sinus venous thrombosis. Dear colleagues, ladies and gentlemen, 5 exciting studies from March 2022. And thank you very much for listening and watching.